Well, it's actually 7 o'clock. Welcome to Mini Med. This is our spring session. Yay. Just to remind you, I'm Joe Romero-O'Connell, Director of Colorado AHEC, and on behalf of Colorado AHEC and the Adjuncts Medical Campus, welcome to all of you and all of our statewide listeners who are attending this first session, the first of 4 exciting April sessions of Mini Med Learning. So before we start, I have to ask you to please confirm your attendance in tonight's session via that QR code. It doesn't matter if you already did it on email. That's what's going to count you as being here. You want to be counted as being here, so you can get one of these fantastic lapel pins. If you attend all 8 sessions, that's 4 in April and 4 in October. You can also get a Mini Med diploma if you attend 6 out of the 8 sessions. And we have a little graduation with some cake and certification and pinning in October. So I know some of you are repeat customers. Yay! Some of you I haven't seen, but yay, welcome. I have the honor every time to introduce our presenters. And our presenters are, as you know, top notch. This is Dr. Juliana Wilson, who's a Colorado native and has worked at the University of Colorado since 2016, where she's an assistant professor of emergency medicine. She completed a residency and a fellowship in ultrasound at the State University of Buffalo and is actively involved in medical education related to ultrasound, emergency medicine, and critical care at the UME and GME levels. She also serves as a co-chair of the UC Health POCUS Committee, POCUS, P-O-C-U-S, Point of Care Ultrasound. So what is this imaging modality? Why do we love it? Well, I think she's going to tell us. Welcome, Dr. Wilson.
Can you hear me okay? Yeah? Okay. I want that energy, right? I worked a shift today and I'm like, oh, can I make it through? So thank you for that lovely introduction. That was very nice. I'm very excited to be here with all of you. I really wanted to make this session hands-on, but unfortunately, since we're all virtual and many different locations, we weren't able to do that. But I really think that's the best way to kind of talk about this skill, learn about this skill and how to use it. Like she said, I am a Colorado native. I always joke with people that I was born at the psych hospital down the road here, which is now Aurora North, but it used to be back in the day a community hospital. See lots of shaking heads, like you must be familiar. Was it Presbyterian?
Yep.
Right?
Aurora Press.
Aurora Presbyterian, right? Okay, so that's where I was born, corner room. So I grew up in Aurora, and I'm back in Aurora now, which is great after all these years. Went to elementary school at Wheeling, which many of you probably know, also down the street. And so here I am. So I went away for med school and residency, but always wanted to come back to Colorado years later. And so I took a job here working in the community. So I think sometimes, you know, when we come and we give these presentations and we work at the University of Colorado, when people work all different locations, they might think like, oh, you've never worked where I worked. But I just want you to know I have worked other places. I may not have worked everywhere. You all have worked in this room, but I have worked other places. So I know what it's like to work in different locations, different states, lots of different things. And then I kept coming over here to teach and they were finally like, you should probably just apply for a job here. So that's what I did. So then I was hired here 8 years ago. And I do a lot of things ultrasound. I do a lot of things medical education. I teach everyone from nurses to EMTs to medical students to undergraduates to fellows to residents to colleagues. So I kind of teach all over all levels, primarily ultrasound, but I also teach a lot of emergency care. So I'm involved in the medical school. I have been for like the last 5 years in teaching emergency care. So I work 100% here at this campus. And so that's where I work clinically. And I also direct the longitudinal ultrasound curriculum at the medical school. So I spend a lot of time doing that as well. And if you can't tell, I love ultrasound. So we're going to talk about it today. I thought I was really clever with this title, but apparently it's really hard to pronounce, right? Resuscitation is what I thought. And then as I started to think about this more, and I was like, this is what I love about ultrasound, but this is what I do, right? I work in the emergency department. This is my scenarios. And so I ended up making this maybe a little bit more broad for everyone, but hopefully we can all talk about ultrasound and all of its utilities in all different areas. So. Okay, so a couple things we're gonna talk about is kind of a little bit of the evolution of focus or point of care ultrasound over time. Does anyone here have familiarity with ultrasound? Used it before? Awesome, that's great. So kind of point of care ultrasound started back in the 90s, and it really started with a fast exam. That was like probably the biggest thing that it started with, and it's evolved significantly. And I really think kind of the biggest uses that I see for it now are really the time saves, right? How can you save time to diagnosis for your patients? How can you save you time, right? By getting that diagnosis quicker and maybe more accurately, some people would suggest. Patient saves, right? Diagnose something more timely manner in a really acute illness. I really love it over the years, I've done a lot of gallbladder scans, I've done a lot of fast exams, I've done a lot of pregnancy scans, but I really love it in undifferentiated patients. And I always tell like my medical students, the ultrasound is like this like flashlight, this extra tool you have, right? That you can use for diagnosis. I don't really think of it as an extension of the physical exam. I think of it as an extra tool, right? That you can use. And there's lots of times when I see people that I probably wouldn't have been able to diagnose them as accurately or as quickly had I not been able to use ultrasound at the bedside with a really specific focused clinical question to try and answer. So, and the other thing that is really, we'll talk about a little bit more, is kind of resource utilization. When you're at the bedside, right, you're asking a clinical question, there's no tech that has to come in and do the ultrasound, or no radiologist that has to read it, and then you have to interpret it. So I just took out all that work, right? And now I get to ask the question, I get to answer it, and then I get to make the decision, right? So not only faster, but all that resource utilization. And we'll talk a little bit more how that affects kind of patient care down the line. So, okay. Anyone know what that is on screen?
Heart.
It is an eye. But we're gonna go over ocular ultrasound a little bit today and kind of talk about how we use it. All right. Okay, so we talked about a little bit about kind of history, what we use this for primarily initially, exams, right? Diagnosing tamponade, diagnose critical patients, ectopic pregnancies. But it's amazing now. I really have a hard time going anywhere where people are not using ultrasound, right? Point of care ultrasound. And part of that is really the technology, right? So everything is different because we have these handheld ultrasounds. They're so easy to access. They're so easy to use. So everyone it can be accessible now to everyone to use it, right? And the applications, right? Literally head to toe. You can use it for everything: musculoskeletal, eye, cranial, cardiac, just so many different applications that we can use it for. And what's nice is like, if you didn't get the training at some point in your life, there's all these tools that can really help you. So there's a lot of AI that aid in image acquisition, help you get the right image, tell you you're getting the right image. And then hopefully down the line, we're gonna work on things that hopefully help you get the right diagnosis as well, okay? So these are kind of the things that this evolution, I think, it's crazy. It's just come so far so quickly in really kind of the short career I've had doing ultrasound, which is a little over a decade. So it says Catherine is requesting to report this meeting. Should I say yes? I don't know. Should I deny?
That might be recording it, right?
Kate, go ahead.
I'm gonna exit.
Oh, Katie.
All right. Talked about all this. We can all show all of these things. We'll talk about some of them today. Okay. All right. So time saves. One of the things that I love, really that allows me in the emergency department to save a lot of time for patients that come in with epigastric or right upper quadrant pain is being able to do a really focused right upper quadrant ultrasound. And then I can either forego their radiology study and discharge them because what I saw was totally negative and it's not really their reason for coming in with their pain. Or I can proceed down the line to get further testing and get specialties involved. So this is one thing I love. This saves me a lot of time for it doesn't require me to do additional testing. It takes me about 5 minutes at the bedside while I'm taking a history, to be able to do it. I know this seems challenging, right? So look at a gallbladder maybe, it is not that hard because you can see a gallbladder here on the screen. Hopefully you recognize this is a gallbladder, right? This is a big gallstone right here in the neck, right? Of the gallbladder, cholecystitis until proven otherwise, right? But some of the things people get a little bit more tricky about is like, well, I don't know if I can look at those common bile ducts, right? Can I really look at those? Do I really need to? Do I really need to diagnose choledocholitis? So there was a really interesting study, and this just kind of shows that you don't necessarily have to. If someone has normal labs and you do a radical quadrant ultrasound, it's totally normal. They have normal wall thickness. You don't see gallstones, normal size. You can probably, they have normal labs, right? So normal biliary enzymes. You could probably forego doing the CBD and you're probably not going to miss anything. There's like a 1% chance, which is kind of nice, right? That you can do this at the bedside, learn it relatively quickly, and be able to offer this for your patients, regardless of the situation. I think even probably, I don't work in the clinic, but I imagine that this is probably a pretty common complaint that people see in outpatient setting as well. So, another time save, focus renal or bladder. This is such an easy ultrasound to do, it really is. Bladder, so easy, you could look at that for masses, retention, all of those things. And then looking at the kidneys, looking for signs of hydronephrosis. You're thinking about kidney stone, right? It's not a perfect test if you're thinking about pyelonephritis, but for kidney stones, if you're looking for hydronephrosis, it's pretty great. So on screen here, we have a kidney. But we have some pretty severe hydronephrosis. These are all the calyces super dilated, usually from a downstream obstruction. And in the right clinical scenario, right, you can think about renal colic for that. This is someone who probably need a little bit more diagnosis, right? With this severe hydronephrosis, so they're going to lose some of their kidney function potentially and may need some intervention. So if I were to see this, I probably would get additional testing. But if I were to see good story for renal colic, I do an ultrasound, it's a very normal kidney, there's no evidence of any hydronephrosis. I just kind of saved a little bit of time, and most people will pass that stone without any issues and have a little bit more information as well for that patient. Okay, so great time save. They've done a bunch of studies showing that like absolutely we can do this. Same as compared, the sensitivity specificity is essentially the same as compared to CT. Detection of hydronephrosis, like we just talked about, suggests a larger stone. And you can really decrease your length of stay, right? And your use of your additional studies, you don't need to use as many CT scans. You can decrease your radiation as well. And it showed no difference in complications at 30 days. And physicians can do this with really minimal training to be able to do this. So this is, I think, a really great one to be able to do. Patient saves. Okay. This is like also one of my favorite things, but I just feel like they don't happen all that often, you know, but when they happen, they're great. That really timely diagnosis. I had a patient that had, he was a young patient, like in his 20s. And he came in with this like great classic story for an aortic dissection. And we were able to do a bedside ultrasound and caught the, type B aortic dissection at the bedside. And I was able, I fortunately work somewhere where there's cardiothoracic surgery. I was able to call them and show them the images before I even had a CAT scan, right? So that's phenomenal, right? Amazing that we can do that at the bedside. Just doesn't happen all that often, right? But it's awesome when you can find things like that. Cardiac tamponade, that shortness of breath that comes in. Think about another patient I had who had a history of breast cancer, and she came in and she was short of breath. She was hypertensive and tachycardic. And I was like, you know what? I'm just going to do an ultrasound of your heart. She was in tamponade, right? Early tamponade, and cardiology took her right away. So, there's just so many things that we can do, these life saves, which are awesome. This is like really, truly like why we as emergency physicians grab onto this and think it's so fantastic, because it really changes the trajectory for a lot of patients and really helps us. So other uses too, just talked about dissection PE. Obviously there's other uses too, ruptured AAAs, things like that, ruptured ectopics, where we can really make some changes for patients pretty acutely. So This right here, let me just explain these images. So this right here is the suprasternal notch. So we're actually taking the ultrasound, we're putting it right here, and then we're aiming it down to look at the aortic arch, okay? So this is gonna give you aortic right here, aortic arch right here in the different branches, and so this is actually a type A dissection, okay? All right. So, all right, why should you do point of care ultrasound, right? Why? Maybe I don't want to change anything in my practice. Maybe I already do it. Maybe I should do different applications, right? So I kind of went through a little bit of the literature to see like what supports us actually doing this, right? Is there a lot of legal risk for doing this? Is there not? Is it help patients for cost? Or resource utilization? Like what's the actual literature? There wasn't a ton, but there was one kind of meta-analysis that they did here at the top right, that basically looked at all the medical legal cases, and there weren't that many. There was definitely less than 10. And most of them, the reason for the medical legal case was actually failure to use point of care ultrasounds, failure to perform it, okay? If you have something that's accessible to you, you know how to use it, and you don't use it, right? If there's an outcome that happens that you could have maybe diagnosed sooner or had a different trajectory for that patient. That's what they found that primarily there were. Bottom line, there weren't a lot, but when you don't use it and you have it available to you, that's potentially a risk. I also was looking at kind of cost-wise, right? So I did this study a couple years ago. It was probably pre-COVID or early COVID with one of the hospitalists, and we looked at lung ultrasound, right? We were sort of looking at why are we doing all these chest x-rays every day? Like lung ultrasound is a really great tool, which has really evolved really since COVID, and we're gonna talk a little bit more about that. But it was really interesting. We had a lot of conversations with a lot of different stakeholders in the hospital. And one of the really interesting things to me, and maybe many of you know this, so these patients that get daily chest x-rays, their chest x-rays actually cost the hospital money, right? There's not enough reimbursement for it because it costs money to send that tech up with the machine, take the picture, radiologist reads it, right? It's really challenging, right? Whereas ultrasound, you can do it at the bedside, you can compare it serial day to day. So different tests. So this group, and I believe it was out of Minneapolis, they took a look at doing ultrasound. So they put people into an ultrasound group and put people into like serial chest x-rays every day and looked at what was their resource utilization, their length of stay, and their hospital costs. So they had like decreased length of stay for an ultrasound group. They had lower hospital costs for the ultrasound group. The only thing they had higher in was there were more chest CTs. And I don't know if that's because they found more in their ultrasounds. They didn't really further explain that. That was the only thing they had more in the ultrasound group. So interestingly enough, I think that's one of the things that we can look at is that resource utilization. Like we talked about, can we do a bedside ultrasound of the gallbladder ourselves? Can we do a bedside ultrasound of the kidney ourselves, right? And again, we talked about these handheld devices are so easily accessible. I think another reason that's really important as far as why you should do focus, patients really like it. Patients really like to be able to see what's going on. They like their physicians doing that, or their caretaker is doing that for them, right? And being able to be explained by the physician what they are seeing and what is happening. I don't know if any of you have ever had an ultrasound and they're like, oh, the doctor will explain that to you, right? And sometimes that's a little frustrating, right? You want to know what's happening. You want to be able to explain that to you. What are they seeing, right? How does this matter in my care today? How does this matter for my symptoms today? So I think that's one of the things patients really, really like too. And I think you're spending that much more time at the bedside, right? You're getting more information. You're spending that much more time at the bedside. It's developing that relationship. So that's one thing I think is really important too. Okay, so a little bit more on the evolution of focus. So I think there's like a couple things really in my career that have really changed a lot in ultrasound. And one of them is pleural ultrasound. So when I started with my ultrasound fellowship, over a decade ago, no one was really doing ultrasound of the lungs. No one. It was like, those are made of air, ultrasound doesn't go through those, we can't see anything. But lo and behold, we discover over a little bit of time that actually we can see a whole lot in the lungs, and we can really use it in a COVID really changed a lot of that as well, right? Because a lot of people didn't want to go in with the X-ray machines. They were much more comfortable taking in this handheld ultrasound to do a lung ultrasound for the rooms. And so we really got a lot more comfortable with using ultrasound of the lungs to diagnose things. Then we started looking about how much more sensitive and specific, or is it, than a chest X-ray is ultrasound. So if you're looking for a pneumothorax, which one's a better test? Chest X-ray, ultrasound. Any guesses? Ultrasound. They're pretty even, actually, those two. Yeah, those two are pretty even. How about if you're looking for a pleural effusion? How about chest X-ray or ultrasound? I hear a lot of X-ray. Ultrasound is a way better test. So do this. If you have an ultrasound and someone has a pleural effusion on their chest X-ray, because it got ordered, maybe not by you, after this lecture, but go look at the size of the pleural effusion on your ultrasound. It's amazing to me. It's a much more sensitive test that we have to be able to use. How about pneumonia? Chest X-ray, ultrasound. X-ray. X-ray?
Ultrasound.
Ultrasound again. That's a way better test that we have, right? So it's really interesting. We are still using, and a lot of this goes back history-wise, right? Many of you are probably not comfortable interpreting lung ultrasound at this point, right? But you're really comfortable interpreting a chest X-ray, right? And that's kind of reflexively what we do. It's what we've done historically. But that's what we're really like trying to change that narrative on, right? So a lot of times I'll go in and ultrasound the patient, look at their lungs before I even look at the chest X-ray, right? And see what I find. So that's something just to think about. It's a better test. Lung ultrasound is a better test. We've found studies that show us that. It's not a perfect test, right? Neither is a chest X-ray. But it's a much better test for pleural effusions than for pneumonia. And for one more, I forgot, pulmonary edema. Okay, it's a much better test for that as well. Or what we like to call interstitial edema. So this is just an example of kind of what COVID looks like. It has a really specific finding on ultrasound, which we discovered, after seeing COVID, is that we saw this really dark spot right here. Does everyone see that kind of up in that area? And you see how this pleural looks really kind of ratty right here. This was really specific for COVID. When we'd see this, we'd be like, oh, this is one of the few things that presents this way because it's peripheral, right? And it does this to the pleura. So this is called a pleural consolidation, and this is kind of how COVID would look on ultrasound. So we got kind of used to seeing that over the last few years. Thankfully, we don't see near as bad as we used to. People see pediatrics in here? Anyone? See pediatrics? No? But you all, many of you probably have kids, right? All right, so this is a little bit of a personal story. But I think this kind of illustrates like maybe how far what the future could really look like. So my kid, I have a 6-year-old now, but last year he was 5. And last year he had this just really persistent cough, right? And she was getting better. We had taken him to the pediatrician for just like an annual visit. And she's like, oh, he's got some freckles on his lungs. And I was like, yeah, he's been sick for like 3 weeks, but he's getting better. Okay, we'll keep an eye on it. So a couple weeks go by, he's like still coughing, right? And I'm ultrasounding him at home. Get him to play a few games on the tablet, do some lung ultrasound. And I am watching this pneumonia develop, right? So I go back to my pediatrician because I try not to be my kid's doctor. And I say, hey, my ultrasound shows pneumonia. And then she's like, I was like, he has pneumonia on the ultrasound. And they're like, okay, well, why don't you go to your chest X-ray? And I was like, well, the ultrasound shows pneumonia. But I listened, I went and got the chest X-ray. He had pneumonia with a pleural effusion, right? But it would have been so nice. Think about the difference, right? I was there in the office. They could have done the ultrasound. They could have diagnosed it, gave me the antibiotics. I wouldn't have had to go to urgent care, get the chest X-ray, have the tech do it, have the radiologist read it, and then get it sent back to the pediatrician. Like, it's just kind of wild, right? And it's easy to diagnose, right? I was doing it at home, right? It's a better test. So kind of a personal story, but I think this is one of the areas where we've really, kiddo's fine now, by the way. I was slightly traumatized by the event, but kiddo's fine. But this is one of the areas where I think we really come a long way, actually. We are using lung ultrasound a lot more. better for the kiddos, right? If we're serially following any type of thing in the lungs, if we do ultrasound, better for the kiddos, it's a better diagnostic test, it's something that we can use at the bedside to be able to do it. And shockingly, they actually tolerate it really well. The kiddos really do. They do really well with ultrasound. A little distraction goes a long way. They actually do really, really well. So, cool. All right. All right. So this is my personal favorite. It's the undifferentiated patient, right? That comes in, you don't really know what's going on. And I think there's a couple diagnoses that I just really love this for. One is for shortness of breath, that's undifferentiated, or maybe you think you know, but things are playing out exactly how you want them to. Or undifferentiated shock is also a good one, and undifferentiated chest pain. These are all ones that I really enjoy using ultrasound because it really helps quite a bit. To give you this example, this was a patient I had a couple weeks ago, but I probably had dozens or hundreds of these over my career. So again, when I first started, we didn't really use ultrasound that much, but there's on the lungs, sorry. But when I first started my career, we were starting to see this, like, gosh, people come in, they're wheezing, right? How do I tell if this is COPD? How do I tell if this is a different process going on? So we started to look at this a lot more. So this patient had come in, history of pretty profound COPD, and EMS had just given her nab after nab after nab. So she's now tachycardic to like 140, right? And had given her sodium medrol, but she is just, so like her work of breathing is very concerning. Like she thought she was gonna die, you could tell. So we get her situated and I stick the ultrasound on and this is what I see, okay? Any idea what this might be? It's hard when you don't know what normal is, right? I think I probably should have showed you normal to begin with. So this is not normal. This is our ribs right here. These are our rib shadows going through here. This is our pleural line right here, okay? And normally we wouldn't see anything below the pleural line. So normal lungs, ultrasound waves hit the normal lungs on the pleural line, they scatter, they don't reflect anything back to us. It's physics, I hate physics, but it's part of ultrasound, so you have to understand it a little bit. But when I have something in the lung, then those ultrasound waves get transmitted and reflect back a picture to me, okay? So when I see a picture, when I'm looking at a lung ultrasound, I know that something's going on with the lungs. So what I see here is, oh, sorry. Oh, did I turn it on? How did I do that? How did I do this? There we go. Okay, fixed. All right. What I see here is I see these are coming from the pleura and they're going down. Does everyone see those lines? Yes. We call these B lines, and it tells us there is interstitial process. And in the right setting, that can be edema. In the right setting, that can be an atypical pneumonia or a viral pneumonia. It just depends on your overall picture. Okay. So I looked at her lungs. I saw this, and she told me she had like the the zip up stockings for varicose veins. She had those on and I unzipped them and her legs were like a little bit swollen. I was like, oh, is this how your legs usually are? And she's like, I've got varicose veins. And I was like, okay, well, let's take another look here. So then I looked at her lung bases and I saw this. So this right here at the lung bases, keep pushing the wrong one, is all black right here. Okay. So she had these big, huge bilateral pleural effusions that alveolus was doing nothing for, right? Nothing for. Whenever we see the spine above the diaphragm, again, it's that same picture of if we see spine above the diaphragm, it goes through the lungs. That is a sign that there's something abnormal happening in the thorax, because I should never see a picture there. It should just be scattered ultrasound waves, okay? So I see this and I'm like, okay, well, I know you have fluid. Do you have pneumonia? Do you have a viral pneumonia? Or is this another reason, right? Mind you, all this has taken me about 30 seconds so far, okay? All right, then I take a look at her heart, okay? So right here, we have what's called a parasternal long axis. This is our right ventricle here. This is our left ventricle here. This is our mitral valve. This is the aortic valve right here. Normally, I'd want to see this anterior leaflet of the mitral valve come up and bounce off the septum. Okay, this is kind of a surrogate marker for kind of global cardiac function. Function is poor, Okay, function's very poor. She doesn't carry that diagnosis, but I get all these pictures together and I look at her IBC, which is also nice and plump, very dilated. And I'm realizing she is having acute pulmonary edema, right? So we get her on BiPAP, we get her Lasix, she peed out 2 liters. Never seen someone pee out so much from just 40 Lasix. And then she's great. She comes off BiPAP, she looks great 2 hours later. But if I would have sort of stuck with the trajectory of like, this is your COPD, I'm gonna keep treating her COPD, she would have not have gotten better, right? So this is where I feel like, lung ultrasound, cardiac ultrasound, really looking at that patient who's not behaving the way you think they should, or maybe they're undifferentiated, and how that really can help change what you do for that patient. Cardiac ultrasound is a little bit tougher. You don't have to get super fancy with all your measurements, but if you can do a good ultrasound, the data shows us that a global assessment of function is just as good as specific measurements as well. When we're trying to look at something like this, we can look at really reduced function, moderately reduced, or normal function. And this is what I would call severely reduced function. Okay. All right. Okay. I told you we'd talk about ocular ultrasound, right? I hope there's no ophthalmologist here. Is there? So ophthalmologists have actually been using ultrasound for a very long time. Okay. And this is something over my sort of career in ultrasound that has really changed pretty dramatically as well. But ophthalmologists use a slightly different type of ultrasound. They use A mode instead of B mode, and they actually place it up directly on the open eye, which, you know, doesn't sound pleasant to me, but they've been using it for a long time. They use B mode now as they've evolved, and it's a little bit easier and nicer for patients, but they've been using it for a very long time. So this is another one where I just really feel like this has really changed how I approach eye complaints and how I look at them. Because pretty common complaint, and I'll kind of lump this in here with headache a little bit, because I put this in there. With headache, we often think about eyes and what's happening behind the eyes with it as well. So say you have this patient who comes in, they have a change in their vision. They're describing it looks a little bit like this picture, right? Okay. Which is great if you have that image, right? But sometimes patients aren't always the best at describing that. Many of you probably would come up right away with a diagnosis, right? I'm sure, and appropriately do it, disposition them and get them in the right place. But instead, you decide to do an ocular ultrasound, okay? So for ocular ultrasound, you actually just place it right on top of the eye, okay? Sometimes I'll put a tegaderm if there's any reason to think they have anything open there, or if I'm concerned about anything, but I'll generally just place it right on the eye. What happens when you put the tegaderm is you get a little bit of artifact from the air that's around it, and it distorts your image slightly. So I usually just place it right on the eye. Lots of gel, make sure your patient is flat-ish, otherwise the gel just goes like this. So flat-ish, okay? That's what a normal eye looks like, okay? I actually got to put a normal in here, which is good. So this is a normal eye, okay? So here, up here, you're gonna have this black line up here, that's the cornea. This is the anterior chamber. This back here is the lens. Right here, we have the iris. This is the posterior chamber. We can see a tiny little bit back here of the optic nerve, okay? All right, anatomy refresher for everyone. But that's basically what you're looking at. So it allows us to visualize the structures really well because it's a liquid, basically, structure, which ultrasound does. Okay. All right. But your patient, you place it on there and you see this. Now, having seen a normal, you can see this is not normal, right? So sometimes we like to break this down into, is there a problem in the anterior chamber or is there a problem in the posterior chamber, right? So this is a problem in the posterior chamber. And this kind of thing waving around at you here is a retinal detachment. Okay. So really, I mean, you stick that on there, right? You're not going to mistake that, right? You know what that is. But there's other things you have to think about too. Vitreous hemorrhages, vitreous detachment. So there's other things you have to think about. But ocular ultrasound is fantastic. We also use it for, you know, anything going on with the lens. We can look at the anterior chamber, the shape of the anterior chamber. We tend not to use it for globe ruptures, but you can use it for globe ruptures. The other thing that sort of evolving in the data is looking at papilledema. So we'll talk about that a little bit here too, and how we can use it for papilledema. And I know you're sitting there thinking like, I could never do that, right? But for retinal detachment, look at that sensitivity and specificity. It's pretty good, right? Not too bad. And this was kind of a convenient study, but it looked at all these patients and compared it to ophthalmology's exam, and it looked at the emergency physician and saw how well they compare. If you get really excited about ultrasound after this lecture, this is a fantastic podcast. It's called Ultrasound Gel Podcast, and they basically go through all of the literature. They break it down really simple for you and display it like this. You can go through the podcast in like 15, 20 minutes. It's a fantastic podcast if you get really excited about it after this. That's why I was saying, I hope there's no ophthalmologist here. But I don't really do fundoscopic exams anymore because I have found that ultrasound essentially takes the place of that for me. In the ER, it's really challenging, right, to do a fundoscopic exam. It's really challenging for me to dilate someone, often for them to be cooperative. But I can see the posterior part of their eye with this, and I can diagnose a lot of things, right, with this as well. So, all right.
Let me make sure I have this in the right order.
Okay, yeah, we're gonna go through one more case. Okay. So that'll probably be it, and then we'll do questions. Okay, so 85-year-old, he's got hypertension, CKD, dementia, heart failure, came in with fever and altered mental status. Your exam, pretty altered patient. Okay, a little tachypneic, a little hypoxic for you. Blood pressure normal, a little tachycardic. This ultrasound here is a view of a short axis through the left ventricle. And then posterior to that, this is actually collapsed lung within the pleura, or within the thorax, and this is a pleural effusion surrounding it. Okay, kind of a wacky looking ultrasound, so I'm going to show you. This is the descending aorta right here. Okay, kind of give you some perspective. All right, you start to get some labs on your patient, because that's probably the most important thing, right, to help with your diagnosis and workup for your patient. You get this. You get this. So in my mind, I see that, and I'm like, oh, this patient's pretty thick, right? I'm thinking about getting some antibiotics right away for this patient, seeing what else I need to do. Get a VBG here, okay, a little acidosis. And some more labs that elevated lactate as well. And some additional now with the UA here, which is pretty unremarkable. So probably not our source, right? So chest x-ray taken forever, and you already know that ultrasound is a better test, right? So you bring out your ultrasound. Well, first you get your EKG, sorry. Then you do your ultrasound. Okay? All right. So any ideas what we're looking at here? Whatever it is, it's on the right and it's posterior, right? Yeah, so this is lung. You can see from the respiratory variation here, right? You're looking at some lung. Okay, we've got a tiny subpleural consolidation right there as we fan through. Now, what's all this? You got it. When we talked about lung, I shouldn't see a picture beyond it, right? Yeah. Well, this all looks like kind of gunk in there, right? We're getting a few more of those, what we call B lines from before. So we're getting some gunk in there, okay? So if I were to see this, it's a little more extensive than this, is very specific, right, for that COVID, right? But when I get to this next field of view, I'm getting a lot more stuff. So I'm thinking about a bacterial pneumonia, okay? So that's kind of what it looks like. I think I really should have put a little one in here for you guys to see that. Okay. So then you're ultrasounding a little bit more. You're taking a look at everything.
Wish I could pause this.
But right here, so you see at the very end, you can see just that pleural line and then nothing below it. The very end of this video, so right here, you see a pleural line and nothing below it. That's normal lung. Okay, the very beginning of this video right here, we're seeing more pneumonia and consolidation. Okay, So that gives you kind of that stark comparison, right? Where you're probably looking at a lobar pneumonia when you see something like that. Here's another example of a lobar pneumonia. You're gonna see those bright white things kind of across the screen there within the lung. So all that lung, right? Filled with debris, filled with bacteria, and then you have these bright white things here. And air is always white on ultrasound. So any idea what that might be? Sorry, what'd you say?
Some sort of a.
Air is always white, so this right here is gonna be air. But why would that be here in the lungs? Any thoughts? When I say you'll be, oh yeah, but these are air bronchograms, right? But this is what they look like on ultrasound, okay? So these are all little bronchioles with air in them. Around it is all bacteria and fill here. And that's the tiny little bit of air that is getting into this lung, okay? Right here's the diaphragm. So right here is diaphragm, so we're looking at a, either right or left base, probably looking at this, the left base pneumonia. Okay, all right. Really easy to make that diagnosis, and there's no question about trying to get a lateral, okay? Because you're getting the lateral right there, okay? All right, kind of another example of those air bronchograms. But what we're seeing here, we can see those white patches right here. Does everyone see how they change though? They get bigger, they get smaller. Whereas if we look at this last one, they kind of stay the same the whole time, right? So these are what we call dynamic air bronchograms on lung ultrasound. This often we'll see, sometimes we'll see it with pneumonia, but more often we usually will see it with atelectasis. Okay, so one of those things we can kind of tell a little bit of difference between the two. So, all right. You get another ultrasound here. So this is also right here. We have liver, we have diaphragm right there, that bright white line. We've got some rib shadows. We've got a really, really gnarly looking lung right there, right? A lot of septations. This would be someone to be very sick. Maybe our patient, but I'd certainly be worried about
Cavitations in here, and this is someone who, more than likely is gonna require a surgical procedure, so.
Cool. So you get your chest X-ray back after you do your lung ultrasound because you're that speedy. You did it while you're examining the patient, right? See, it's even more timely. You probably didn't even need it. Someday we'll get there. You see a consolidation there too, right? So maybe while you're learning lung ultrasound, you do both, right? You compare it to your CT, you compare it to your chest X-ray, and then you get much more comfortable with doing it, right? So you can see what you're seeing on what you're used to seeing on chest X-ray, and then we can sort of shift that paradigm as well. So, perfect. So see that consolidation there. All right. You put the patient on antibiotics, put them on oxygen, you're gonna admit them. But then the nurse is like, wait a minute, thank you. The nurse is like, wait a minute. Their blood temperature is 80/40. Now what do you do? Right? Classic. It's like happens to me on a daily basis, right? Now what do you do, right? Well, first I might be asking, okay, what's our code status, right? What is our code status for this patient? What are their advanced directives? Most of the time I have no idea, so I'm trying to just do the best I can. But I'm gonna go ultrasound the patient again. I'm gonna go take a look at their heart and see what that looks like, okay? So this is another example of that parasternal lung axis that we looked at earlier when we had that shortness of breath patient. Right here, we're having right ventricle. This is our interventricular septum. This is our left ventricle right here. Right here, we have our left atrium, mitral valve here. And remember how we talked about this anterior leaflet of the mitral valve? We really want that to hit the septum right here. And then it is, right? So this is actually a really good looking heart, okay? This heart's functioning well, okay? I don't think the heart is the reason for that blood pressure, okay? This is just a short axis view, kind of looking at the same thing, but again, showing really good function of that left ventricle. So here we have right ventricle that kind of lays on top in that crescent shape. And then we have a left ventricle right here, kind of like a donut, right? We're showing the mitral valve right there. Where we can see symmetrical squeeze all the way around, normal looking ejection fraction. Perfect, we get an apical view. You're pro already, you get this perfect looking apical view. Function also looks pretty great.
I can see that the right ventricle looks about 2/3 the size of the left ventricle. So I'm thinking, well, it's probably not a PE that's causing this, right? That's probably a little bit lower on my differential now. Probably don't have pulmonary hypertension, okay? I'm looking at a pretty normal looking left ventricle and right ventricle now. Look at a subxiphoid. This is really great for when you're looking at a pericardial effusion. And doesn't give us a whole lot of detail about everything, but we can see the function still of that RV and that LV. Perfect. Then I take a look at the IVC. So one of my colleagues, Dr. Von Brown, who you may know, has two really great phrases, and I can't take the credit. But this is what he calls the sliver in the liver. Okay. When the IVC is really big, he calls that the river in the liver. Okay. I can't take the credit. They're just too good. But here's the liver right here. We're pointing that probe up towards the heart right here. And we're looking at this IVC right here. Normally we want the IVC to be somewhere between like 1.7 and 2 centimeters, and we want to have a little bit of respiratory variation. This IVC is struggling, right? It is flat, it's collapsible, right? So there's definitely a problem here with either volume or maybe distributive shock, right? So now I'm starting to think hypovolemic, distributive shock, right? When I look at this ultrasound. This is not a perfect test. There's lots of studies that show like this is hard. So I never use this in isolation. We just can't reproduce when we're looking at something in isolation. But it's a fantastic test when it's at one end or the other, okay? When it's really big, I'm thinking about cardiogenic, I'm thinking about obstructive shock. When it's really small, I'm thinking about hypovolemic or distributive. But I'm always putting that in the context of my entire clinical picture. I can't just use this in isolation. Not a good test for that, okay? All right. So now based on this, we're thinking about that distributive hypovolemic shock, right? Now I know I can give that full sepsis bolus. I can start Fessers if he's not doing well after that, okay? I have one more case, but I think I'm like down to the end. I'm just gonna go over this rush exam. Does anyone remember the rush exam? It's been around a while now. But it's sort of a systematic approach to when you think about someone with undifferentiated shock. So it's really called the rapid ultrasound in shock and hypotension. And it kind of focuses on the area that can like give you the answer you're looking for. So usually if I have someone that comes in with shortness of breath, I'm starting with the heart, the lungs, right? Maybe I'm looking at the IVC. If I'm thinking maybe this is PE, I might be doing a venous ultrasound, right? So those are the kinds of things we look at. We're thinking about hypotension hemorrhagic, right? Or hypovolemic. We might think about doing a fast exam, looking at the aorta, again, looking at the lungs, maybe looking for a distributive shock source with pneumonia. So I like this. I don't always follow it, and I don't always do all of it, because I think it's a great idea to think about all the sources where maybe things are coming from. But I just like to focus on what my patient complaint is and really try to get the answer from there. So, all right. I just wanted to mention one thing. There's a really fantastic website that one of my colleagues at Denver Health developed. It's called the POCUS Atlas. And the emblem is like down here at the bottom of these images right there, the POCUS Atlas. You can go on that website, you can see all kinds of normals. You can see all kinds of abnormals. It has great tips for the evidence behind every study that we do with ultrasound. You can look at those sensitivities, specificities for chest X-ray and lung ultrasound and tell me where I was wrong, okay? But it's a really great reference if you just want to go look at some ultrasounds, okay? Because they've all been vetted by peers and stuff, so. All right.
Thank you so much.
Yes.
Those images are amazing. Thank you. So we're going to use the microphone to ask questions. So we're going to take a question first from the audience that is present here at Anschutz Medical Campus. If anybody has a question, we'll bring the mic to you. We have to use the mic so that the people in the state of Colorado can hear your question. So, any questions?
Curious if I go to the doctor and I say, why don't you do an ultrasound? What do you think most doctors would think or say? Little old me telling them I think the ultrasound's better now that I've been to your class.
Well, I mean, having been through this myself, right, with my son, I think we're just working on changing that dialogue, right? We've come a long ways, but I still think we have a ways to go, right? Really trying to change the narrative and, getting people to do it, feel more comfortable with it. It's hard. We have all this technology now, but we have people that were trained a while ago and that's not part of their clinical practice, right? So I get that. But I think just being like, oh, I know this is a good test, like, do you think this is something you can do? I don't know. It probably depends on your relationship. I felt very comfortable being like, here's my ultrasound image. I think this is what they have.
Lost our view of you.
Oh, sorry. I'm sorry. Governor. But, you know, just working on trying to shift that narrative. It's not gonna happen overnight, but I think we're trying to get there. We're trying to do better things with the technology we have. Question. Oops.
Question.
Didn't earlier.
How long is the training process to be US certified as a physician?
Yeah, good question. There's actually, just as kind of a long tail, there's a couple different ways to be certified. So CHEST has a course you can do that really focuses on cardiac and lung ultrasound. I belong to ASAP, and so they just developed a focus practice designation test, which I just took because they just developed it a couple of years ago, that you can do to be certified, but there's no real certification per se other than those two that people recognize. So a lot of people will do an ultrasound fellowship, they will get training, they'll go to a course, they'll do CME, and it really goes back to a process of wherever you work, whatever your facility is, like how do they credential you, and how can you go about that process there. Certification wise, there's only those two limited avenues, and I wouldn't expect people to do that at this point. So what we do is we'll train people in a specific application. We work with them. I go through all of their studies. We get them credentialed to that application. We make sure they're comfortable. And then you do quality assurance as they do studies on patients and make sure they're interpreting those exams the right way. And that's kind of the process we've developed at the ANSHU's campus as well for all the specialties and kind of on all the departments. So.
We'll take a question from this audience now. We have Fran over there.
But I could reach over, but then I realized I'm not, long enough.
I could have got nothing to come to you also. Thank you. Has there been any uses of ultrasound in a curative sort of way?
There probably is. Definitely for procedures. I didn't bring that up because I felt like that was a whole other topic. But a lot of procedures that we use it for, I would say that's more along the lines of like at least treating pain, right? Yeah, or interventional radiology, yeah. So like those kinds of things, definitely procedures for treatment for pain, for different types of pain syndromes for sure. Yeah.
And I know a lot of people use it for,
Yeah, definitely diagnostic. I do primarily diagnostic ultrasound as well as procedures as for, vascular access or other kind of procedures, but yeah.
Could you comment on the increasing capability of using Doppler during ultrasound, and have you seen more clinicians using Doppler?
Yeah, I mean, so Doppler has been around forever with ultrasound and it's pretty great. We have it on our handheld devices even as well. And so I don't know that there's been a huge change in that other than it's just really widely available on our handheld devices. For me, Doppler, I primarily use for cardiac imaging when I'm looking at things like cardiac output. I'm looking at sort of volume responsiveness in a patient. I teach the critical care fellows too, so we use a lot of it for that. On a day-to-day basis, I don't use it as often, but certainly vascular imaging too, it can be used for. So.
That's a great talk, by the way. Thank you very much. Does it detect cancers? And if so, when I'm in the ER, let's say, and you've all of a sudden discovered something kind of nasty that I'm not aware, what's that conversation in the ER? Is it just your tests? We have some concerns about your test and get referred to oncology, or how does?
Yeah, so that's a really unique thing about point of care ultrasound. So very different from what radiology does. So when radiology does a right upper quadrant ultrasound, they're looking at the entire liver, they're measuring the kidneys, they're looking at the aorta, they're looking at the IVC. When I go do that, I'm looking at the gallbladder. So me having done this for a very long time and looked at a million ultrasounds, if I see a cyst in the liver, I'm gonna recognize that. But when you're doing a focused ultrasound, you're asking a focused question, you may not look for all of those things. Does that make sense? And so I think there's some concern like, oh, are you missing things right? Is there a medical legal associated with that? It really hasn't really been shown to be the case because you are asking a focused question. I am asking like, is your pain due to your gallbladder? And I'm gonna look at your gallbladder and answer that question. So when I see things, I refer people, if I don't think it's, part of their care. If I think it's part of their care that day, I will probably get additional testing if needed. Yeah. Yeah.
Go ahead. Can ultrasound be used for diagnosing tuberculosis?
Oh, that's a great question. I don't do a lot of global health, but there actually is a really specific exam and I'm blanking on the name for it. I think it's called a FAST exam. It's similar to FAST. And there are 4 different parts of it. And if people have 2 of those parts, even without a TB positive test, it's pretty diagnostic for TB. So yeah, I don't know the exact numbers because I don't do a lot of global health and we don't see a lot of TB. But yes, there absolutely is. Yeah.
Yes. I don't know.
This goes back to your primary, a doctor's office. Is it something that would be cost effective or something that doctor's offices would have access to for ultrasound? Because I mean, it's not funny, but it is funny because I had ovarian cyst on my left ovary that I was told by my primary care that it was a kidney stone, most likely. No diagnostic, nothing. They kept telling me to strain my urine for this kidney stone. And I was in an incredible amount of pain for a long time and never found the stone until it had finally grown into my sternal knot. And I couldn't keep anything down. I finally asked my brother to take me to the hospital. And it had, grown up and I had to have emergency surgery to move it and it was, negative. And I just think of how easy it could have been because I was referred for a CT scan because I had gone back to that. And they're like, well, maybe it's something else. We'll have it. Not maybe it's something else. We'll have you go for a CT scan for your kidney. And I didn't make it to that CT scan. So I went to the emergency room for one. And they were like, well, you don't have this kidney stone, but it's the largest cyst we've ever seen in our life. But anyhow, that and the time that would have been saved for my dad when he had a retinal detachment in the ER, when we were waiting for hours after, and waiting for the scanner and stuff, when he could have just had the ultrasound. I mean, it's just kind of like
technology is evolving, so we have to go through that.
No, it's okay. I'm just,
Yeah.
and it was 20 years ago. So, maybe the technology wasn't around. Most likely it wasn't around. Definitely wasn't talked about, I'm sure, but
Probably not.
just wow.
But yeah, I think with handhelds, like they are affordable. So I didn't bring my handheld, but the butterfly handheld was about $2,000. And you just hook that up to your phone. And so they are really affordable now. And most of the handhelds are right around that range, like $2,000 to $4,000. But again, it goes back to, is that provider comfortable using it? Have they been trained in it? So just trying to shift that narrative, right? We have this technology, we need to use it safely, we need to use it wisely, and what's best for the patient. Yeah, absolutely.
We have a question here, but one from the Zoom first and then you, and then we'll have to call it a night. So the question is ultrasound being used for scleroderma in the fingers?
Okay. I do not know the answers to that because that is not my field. I know that dermatology uses it. They use something really specific called elastography, which can look at tissue deformation. And I know you can look at the digital arteries and look at the velocities for like Raynaud's, but I do not know the answer to that.
Okay.
Yeah.
Thank you. Go ahead for the one last question here this evening from the audience.
Well, thank you for the great presentation as well. But yeah, I think it was a interesting talk of looking at different specialties and how they use it in their day-to-day. Kind of for me more in the field of urology, it's more commonplace. I was kind of surprised that it wasn't commonplace in different specialties. I mean, handheld devices all the time to do like residual ultrasounds, biopsies as well.
Yeah.
But are there any specialties where you see there's kind of a need or where this technology could be implemented larger scale to be more efficient?
I actually think all the technology, all the specialties are really latching onto this, and they're really starting to use it, you know, in those ways that matter for that specialty. Specifically for yours, but yeah, we're seeing our nephrologists starting to use it, we're seeing a lot of people using it, so, yeah. So I was gonna try to get my pediatrician in.
It's always sad when we are having such great discussion to call it a night. Once again, a big round of applause. Thank you so much for joining us on this lovely spring evening. Please join us next week when our topic will be on the menstrual cycle and contraception. IUDs, Nexplanons, and pills. Oh my. And it's by Dr. Ari Nestler. So hopefully we'll see you next week. Bye-bye.